Hi, Dr. Garima here, shooting a video again after a break. No matter how hard I try to be consistent, life happens, Life, more than life, I would say my toddler happens. And then, yeah, things happen and then other things get deviated. Anyways, this last month was so busy. Like I mentioned in one of my previous videos, I was kind of winding up from one of the clinics and shifting my practice to the other two clinics. So that was going on, and other many things. And this month is also going to be so busy. By the way, happy Dhanteras, all of you all. To the unknown, it's an Indian festival, and it's a nice festival, basically, one of the biggest for us. So, anyways, let's go back to solving another Australian Dental Council question. Uh, Now I'm starting with mock 3. I have finished mock 1 and mock 2. Mock 3 is a mixed mock. Mock 2 was predominantly prostho questions. So if any time you wish to strengthen your prostho, just go through all of my videos of mock 2. You can just type on the search engine Dr. Garima mock 2 ADC questions and you'll get all the questions, around 11-12 of them. So in that I've given various explanations of various topics. Going through that would be a good way to prepare for the prostho subject with respect to the ADC exam. Let's start solving mock 3, and again, to all the new candidates, how you can enroll with me, because I keep on getting all your messages just to streamline the process. You can get the books for free on the Target ADC Facebook group. You have to send in your request. I'll approve it. I approve it once a week. And then if you have given the answers to the questions that I've asked, and you can have all the books for free in the file section of the group. And if you wish to get enrolled to get the other study materials and the mocks, which are the key to solving the exam, then you just have to email me on adcwrittenmocktest@gmail.com, or you can just Instagram me or Facebook message me. Anything is okay, or you can just leave a comment on the YouTube and I'll send you the links. So about that, all right. So let's start solving. A 55-year-old female presents at your surgery complaining of extremely sharp oral pain of a few seconds duration. Very, very important keyword. Sharp oral pain. The word sharp is very important here. Few seconds duration. It arises whenever she touches an area of her skin above the right-hand side of her upper lip, adjacent to the angle of the mouth. The patient is fit and well and is not taking any medication. So she's an elderly patient. She is 55, and there's an intraoral picture given where you don't find much of an issue except probably a little bit of caries on the second molar. She's fit, not taking any medicine, but she says whenever she touches this area, which is like a trigger area, that's the key word, trigger, because touching on the area elicits a sharp shooting pain, meaning it's a trigger area that is eliciting a sharp shooting pain. So whenever she touches on it, severe pain happens. Classical signs of all of us know of this one syndrome that we have read about, that's trigeminal neuralgia, right? But then again, there is one more nerve which elicits the same thing, but in the throat region. That's the glossopharyngeal nerve. So if a person says, I'm having severe sharp shooting pain for a few seconds, whenever I'm coughing, sneezing, swallowing, touching my throat area, then it is glossopharyngeal neuralgia. See, these are very simple to differentiate because trigeminal neuralgia, how does this nerve come? You see, this is how, trigeminal. Tri means 3, coming from 3 germs of the nervous system. 5th cranial nerve, ophthalmic, maxillary and mandibular. These are the 3 divisions like this, okay? And one of those divisions, if it's creating an issue, then this is what happens. Now you found out that the patient is dentally fit. So you have already determined that the patient is dentally fit. What could the provisional diagnosis be? It's a provisional diagnosis, not a definitive diagnosis. So by the first glance of everything, automatically your thought process should go to trigeminal neuralgia. Now even if you're confused and you think maybe the other options are right, let's start ruling it out. Migraine. Migraine happens in this region, and it can be sharp shooting, but it doesn't last for few seconds. It can last for more than that. And secondly, it doesn't have a trigger area. It can just start without touching anything. Atypical facial pain. Atypical facial pain can mimic trigeminal neuralgia, but it does not have a trigger area. It would be vague, like just happening anywhere without touching anything. Glossopharyngeal neuralgia, I just explained. It's in this region, the ninth cranial nerve. Do you remember the cranial nerves, by the way? Come on, quickly. Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, auditory, glossopharyngeal, vagus, spinal accessory, and hypoglossal, right? Anatomy, first year BDS, you should remember. If you're not remembering, please do remember. Yeah, fun fact, don't call me crazy, just as a fun thing, I taught all the 12 cranial nerves to my toddler 2-year-old. He speaks it now. It was just a fun, but yeah, and that's why probably I remember it now, not that I remembered it 5 years ago. So no, I'm not that crazy. So yeah, just while making him remember all this, I remembered, and I'm just showing off it to you. So yeah, but you should remember the 12 cranial nerves, especially because we deal with this region. So anyways, glossopharyngeal neuralgia we just spoke about, and trigeminal neuralgia is the answer. Post-herpetic neuralgia. Okay, post-herpetic neuralgia again does not have a trigger zone. It affects one side of the face, but it does not have a trigger zone. So thereby you can rule out and choose the answer trigeminal neuralgia. Now, assuming you have chosen the correct answer, second question is based on the first question, which is what is the most common cause of this condition in this patient age? Most common cause, meaning all the causes would be correct. Always, always, always remember the word most, the adjectives. Whenever these words come, they are very specific keywords for the exam. That means it's going to be a confusing question because all the options would be correct. So which is the most common cause? Viral infection with varicella zoster virus, acute fungal infection, streptococcal, multiple sclerosis, vascular. Okay, let's start ruling out. Viral infection can be a cause, but it's not the most common cause. Not everybody gets affected with varicella virus. Fungal infection is out of question. It's like very rare probably. Streptococcal infection can happen. Multiple sclerosis and vascular pressure. See, multiple sclerosis will have other problems also. So not everybody having trigeminal neuralgia has multiple sclerosis, but vascular pressure is the most common. So basically there are blood vessels around the trigeminal germ, and it can ganglion basically from where the nerve is coming out, and whichever branch of that nerve the blood vessel is pressing onto it, it's gonna create problems. Now, sometimes if the blood vessel is pressing on the entire ganglion, all the three parts would be affected. And if it's pressing on both the ganglions, the entire face would be affected. Crazy situation. The patient must be so tortured when that sharp shooting pain happens. You know, sometimes in men, when they come, they, like kind of shave the entire face, but they let remain a particular area because that's the trigger zone, because they're so violently afraid of touching that area by anything, because they get that severe, tormenting, sharp shooting pain. So, no cause can be determined. It's vascular pressure unless you do determine something. So, the most common cause indeed is vascular pressure, and the less common cause are all the above things. So, trigeminal neuralgia, the classic trigeminal neuralgia, just has one branch of the nerve affected. Like it can be either ophthalmic, maxillary, or mandibular. A non-classic variety will have all the three divisions affected on both the sides. Okay, so it's not like trigeminal neuralgia is just sharp shooting pain on a trigger zone on one area. It can be a non-classical part also. So don't forget that. Now, what is the most common drug of choice for treating this diagnosed condition? So again, you see question 3 is based upon question 2. Question 2 is based upon question 1. If you answered question 1 wrong, 2, 3 again go wrong. So Tegretol. Tegretol is carbamazepine. That's the drug of choice. Now, what is that drug? Basically, that drug is for treating. It's basically a mood stabilizer. Okay, so it's widely used in treating depression, bipolar disorders, and epilepsy, and it has found a good use in trigeminal neuralgia. So Tegretol is the brand name of the generic form of the drug called as carbamazepine. Oxcarbamazepine is another drug. It's not carbamazepine. So don't jump to option B when you have option A, which is very specific carbamazepine, very famous brand name Tegretol, and that's where they have given it. Gabapentin, phenytoin, ibuprofen. Ibuprofen is a painkiller. It's a non-steroidal anti-inflammatory painkiller. It doesn't work on the central nervous system. It's a painkiller, but not for trigeminal neuralgia. Phenytoin, gabapentin are not the answers for this. They are all used as, they can be used in epilepsy, they can be used in anxiety, but not for trigeminal neuralgia. Now, when pain affects all three divisions of the trigeminal nerve and often bilateral, is known as, I just spoke about it, right? Trigeminal neuralgia classic. No, the classic variation is always just a certain area on one side of the face with a trigger zone. Glossopharyngeal neuralgia, perfect. Now look at this option, okay? The question is saying when the pain affects all three divisions of trigeminal nerve, they are telling you it's the fifth nerve, and the option B is the ninth nerve. You see, it's a gross wrong option. Like, it's like literally a platter served to you. Please don't choose me, like that. So be mindful. So that option is out of the window. Option 3 is trigeminal neuralgia, non-classic, the way we spoke about. That's the answer. Post-herpetic neuralgia. Again, if the nerve is affected, specifically, post-herpetic is after you have suffered from herpes infection. That is totally another condition, absolutely. You don't have to choose that. So option B and option D are straight away out of the window. You can be confused between option A and C, but the question is so good. It just says it's affecting all three divisions. All three divisions is a non-classic variety. A classic variety is just one division of trigeminal nerve. Usually it's the maxillary division. If the patient was in her 30s, like if the patient was young basically and complained of a similar pain, what would be the likely cause? Likely cause. Okay, now this question can have two answers. Okay, it can be one of those unmarked questions. If you don't know what unmarked question is, please go through my video of the mystery of unmarked questions. You will understand what that is. So you can choose two answers in this. Options are multiple sclerosis. That's one of the right answers. Cluster headache. Atypical facial pain. Paroxysmal hemicrania. No, none of the above. So you can choose multiple sclerosis or atypical facial pain. See what happens. Multiple sclerosis is basically degeneration of the nervous system. The myelin sheath gets degenerated and nerves in various parts of the body start to have the same symptoms as one would experience in trigeminal neuralgia. So if the person is having an onset, okay, in young age of multiple sclerosis, it can mimic the symptoms of trigeminal neuralgia. So that is very difficult to then diagnose if the patient is also having trigeminal neuralgia simultaneously with multiple sclerosis. So that is one, and atypical facial pain is also the second one, but I would not choose atypical facial pain that much as it does not have a trigger zone. Okay, so you can choose option A or C, but I would still prefer option A because of the explanation that I've just given. So yeah, pause this video, or after this video go ahead, read more about trigeminal neuralgia, read the drugs, read other types of drugs which can be used, read the treatment methods apart from carbamazepine. I think decompression of the nerve is one of the methods. Then cutting off the nerve, some hemisection. Various methods are listed if the pain is like unbearable and it's like frequent in nature, like some form of treatment has to be done, right?